Hi there, fellow physiotherapists. I am Helene van Aswegen, your host for Physiotherapy Trauma Talks, where we discuss everything related to trauma care. So if you are passionate to learn more about physiotherapy in the field of trauma to ensure that you provide the best possible care for your patients, then this is the right podcast series for you. With me today is Professor Timothy Hardcastle, who is head of Trauma and Burns Clinical Department at Nkosi Albert Luthuli Hospital in Durban. Tim is also an honorary associate professor in research at the Faculty of Health Sciences at Durban University of Technology and honorary associate professor of trauma and surgery at the University of KwaZulu-Natal in Durban, South Africa. Tim, thank you for joining me today. It's an honor to have you as a guest for this episode. I know that you've published extensively in trauma care related to trauma in South Africa, but also on a global level, which certainly makes you an expert in the field. So it's lovely to have you with us as we explore the role of the trauma surgeon in managing patients with multiple injuries. Welcome.
Thank you.
Okay, as we start off, can you tell our listeners a little bit about yourself and how you found yourself working in trauma care?
Okay, well, I grew up in Belleville in Cape Town, and in my high school days got involved with the South African Red Cross Society as a school first aider. And as I got slightly older, was able to work on the ambulances. And then when I started university, hoped to get into medicine, ended up doing a first year of BSc, and then followed by the scores that were high enough, and I got into medicine at Stellenbosch, did my medical training there. And from my second year already, I would be found on weekends helping out in the trauma unit, suturing patients, helping put catheters in, all that kind of things to get experience. And once I qualified, came up to KwaZulu-Natal to do my internship at Edendale, where it was in the middle of it was 1995. It was just post-apartheid, and there was still quite a lot of violence. We saw lots of trauma at Edendale. And then went back to Cape Town, worked as a medical officer for a year in the trauma unit along with the ped surg unit, and then got my registrar post in surgery, did my surgical training there. And I think a total of about 15 months, if you include the ICU time, was trauma. When I qualified in 2002, I was asked to run the trauma unit at Tygerberg for the next 5 years. I was initially in a junior specialist and then a senior specialist position attached to the University of Stellenbosch. And then in 2008, beginning of 2008, I was recruited by David Muckett to move up to Durban as his number two for the newly opened Nkosi Albert Luthuli Central Hospital, where they wanted to set up the trauma fellowship training program, but there was nobody registered in trauma surgery, which in 2007 I'd been registered in trauma surgery. Was one of the first 15 people that were so-called grandfathered into the specialty. And the rest is history, as they say. Then it's a case of just slowly working on a PhD, working on promotions, working on eventually taking over the running of the unit from David Muckett. So the passion was there from a young age. Initially, I wouldn't have thought of going into surgery, but emergency medicine didn't exist at the time, and surgery was then the route to trauma care. So that's how I ended up doing trauma.
Yeah, fantastic. And based on your experience over the years, how would you describe the trauma context in South Africa? What type of injuries do you often see in your emergency department and the causes of those injuries?
Look, it's a wide spectrum. If I think back to my time at Tygerberg, which is a more general emergency department, we would see everything from minor wounds that were true accidents, someone cuts themselves in the kitchen and they have a tendon injury or what have you, right the way through to polytrauma patients from multiple gunshots, multiple stab wounds, severe car crashes, falling from height, industrial incidents. Where I work now, we primarily set up for the ICU care of the complex trauma patients, so we see a lot more blunt trauma than penetrating, but it's still around about a 60-40 mix, whereas
Okay.
in the more general emergency departments, as much as 60% can be penetrating and 40% blunt. We're kind of the opposite because we set up for the complex patient that needs neurosurgery and plastics and vascular intervention, compared to the sort of general surgical units that can manage the straightforward stab abdomens and gunshot abdomens.
Yeah.
If you look at the spectrum, probably of our penetrating trauma, still in this country, about 60 to 65% will be stab wounds, and about 35 to 40% will be gunshots. And then in the blunt trauma, it's probably about a 50-50 mix between blunt assaults, beaten over the head, beaten with sjamboks, these guys that have then got crash syndromes, and then motor vehicle crashes. And again, in South Africa, our motor vehicle crashes have a very strong slant towards pedestrian injuries, and that's because people just don't obey the road laws. Compare that to the US or Europe, where the car crashes will be 90% car or occupant,
Yes.
and about 10% pedestrian, whereas here it's 30 to 50% pedestrian.
Yeah, so definitely a bit of a different trauma landscape. And
Absolutely.
the average age of patients that present to your emergency department, would they be young adults or the elderly, or is it a mixture?
It varies by mechanism of injury. We the knife and gun club, as we like to call them, usually made up of scabengas, or people who are walking home from church and just happen to get shot.
Sure.
They are generally in the younger category, sort of 16, 18 years of age up to about 35. The groups that have the pediatric group, we see mainly pedestrian collisions, and then kids that fall and hit their heads on something, they fall off a jungle gym or what have you. And then a lot of pediatric cases will be burns, quite severe burns. In the older category is often your pedestrians as well, but also drivers, occupants, and sometimes the industrial crashes and the industrial incidents will be in the older age group as well. Unfortunately, what we do see in the older age group is a lot of particularly older females who've been robbed and beaten up at home, and elder abuse is becoming a big problem, just as much as child abuse and pregnant woman abuse is a problem.
Okay, yeah. So when a person with these types of injuries present themselves at the emergency department, what principles guide your management of these patients?
So internationally, the sort of standardized approach, and with certain exceptions, is what's known as the ATLS approach, or the Advanced Trauma Life Support approach, which is based on a course that's taught through the American College of Surgeons, currently in about 88, 89 countries worldwide, so about half the world. Sure. And that's based on an approach to saving the trauma patient's life by dealing with what kills them the quickest first. And so depending on whether there's active bleeding, if there's active external bleeding, you control that first. Otherwise, you, in the order of preference, go secure the airway, protect the cervical spine, assess breathing, intervene if necessary, assess circulation, start treating bleeding and shock, look for where the patient is bleeding, assess level of consciousness, and if necessary, you might have to secure the airway based on level of consciousness, and then keeping the trauma patient warm, but at the same time undressing them completely so that you can examine the whole body, because you don't want to miss little holes and miss things on the back or
yes, definitely
occult injury.
Yeah.
So that's the sort of first phase. We call it the primary survey.
Okay. And then what would follow?
Once that is done, we move on to what we call adjunct. So that's where we do some basic x-rays, chest x-ray, pelvis x-ray for blunt trauma, use of ultrasound to make sure that there's no intra-abdominal or intrathoracic problems. And then we move on to what's known as the secondary survey, while we send off bloods to the lab. And secondary survey, you literally start from the longest hair to the longest toenail, and you examine the whole body from top to toe.
Okay. So it's a very detailed investigation.
Yes. And if you cut steps, that's when things get missed. And it's a team effort. It's not just in the real world situation. When we train ATLS, we train as one doctor, one nurse, one patient. But in the real situation, you're dealing with a team. So if you're lucky, even in a small hospital, you'll probably have at least 2 doctors around. You'll have 2 or 3 nurses. You'll have you might have the cleaner and the porter who's going to help you with your log roll. In a small hospital, in a big environment, in my hospital, for example, there will always be a consultant in charge of the resus. There will be between 2 and 3 doctors and 2 and 3 nurses. There'll be a radiographer with a mobile X-ray machine. There'll often be our critical care technologist who brings our video laryngoscopy device and is available if we have to rush the patient into theatre to run the cell saver for us so that we can harvest and clean cavity blood and give patients their own blood back again.
Okay, that's very interesting. So it's a real team effort, and
absolutely,
and to the patient's benefit, I'm sure. How long would the primary and secondary survey take of a particular patient?
It's a variable time, and the primary survey probably shouldn't take you much more than about 15 to 20 minutes, depending on how much you have to intervene. So if the patient's got a major airway issue and you need to set up your team and do an intubation and pre-oxygenate and prepare everything properly and do a smooth intubation and get someone to hold the C-spine while you do it, because you don't want to intubate patients with collars on and things like that, then the primary survey may be prolonged. But ideally, you want to go through the basics of the primary survey in around 20 minutes, get your adjuncts done over the next 10 or 15 minutes, and then by the end of the first hour, you should have at least 3 more advanced imaging have completed your secondary survey. There are always exceptions. Some patient will come in and his airway and breathing is okay, and he's got a belly full of blood and no blood pressure, and the only way you're going to deal with that is stopping the primary survey right there and moving him to the operating room and stopping the bleeding surgically. So your primary survey might take 5 minutes, but it then has to be continued once the patient is completely resuscitated and the bleeding has stopped and you've got them in the ICU.
Yeah. And then I suppose management of pain would be at the forefront of your mind after you've stopped all the catastrophic bleeding and done your primary survey. Is there any particular types of drugs that you administer for pain management at that stage?
We're very fond of what we call multimodal analgesia. So in the acute 72 hours, we don't like using non-steroidals because they hit the kidneys, they worsen the blood clotting. The drugs of choice that we use is a mixture of an opioid, and there's quite a few on the market. So from the cheap stuff like morphine all the way up to the really expensive stuff like fentanyl or sufentanil. So we'll usually combine an opioid with, and we like the use of ketamine because it's both analgesic and sedative. So particularly in the head injuries, we've moved away from propofol and we're using quite liberally ketamine. It's also good if you have to intubate them in the resus area on ketamine. You can keep the ketamine going, and the anesthetist will take over the anesthetic and do a intravenous anesthetic with the ketamine, and you can continue it in the ICU for analgesia.
Okay.
The one inverted commas non-steroidal that is safe in the early phase is paracetamol, and if the patient is in extremis, we can use that as an intravenous paracetamol. 1 gram of that is equivalent to 10 milligrams of morphine. So it's a morphine sparing. And we'll often use the 3 or 4 in combination. And then we may or may not add a sedative drug. So the problem with certain of the drugs like propofol and the benzodiazepines, which people are inclined to, the old morphine midazolam, strong arm intubation is hopefully dead and buried. But midazolam, for example, gives you some sedation. It also drops your blood pressure, and unfortunately gives no analgesia. So we like to use a combined thing. And then once the patient starts recovering in the ICU by about day 3 or 4, unless they've got further major surgery planned, that's when we'll bring in things like nonsteroidals, lignocaine infusions, especially if they've had abdominal surgery. We like to use lignocaine infusions because it doesn't cause an ileus. And particularly the combination of lignocaine infusions and ketamine works very nicely.
Okay, that's very interesting. And in general ICU settings, there's this concept of trying to awaken the patient much earlier during the ICU care than what would have been done 10 or 20 years ago. Is that also a principle of management in a typical trauma ICU setting?
Again, it depends on the patient, and it depends on what's been done for them. So if they've got a traumatic brain injury, and again, this is not a universal thing, but in our unit, they get full sedation and ventilation for a minimum of 48 hours, which we call neuroprotection, and then we will reassess and wake them up. If they haven't got a traumatic brain injury and they're not a damage control laparotomy that's got a temporary closure and we know has to go back to theatre in 24 or 48 hours, yes, then we will certainly try, and we certainly, maybe not so much sedation and analgesia hold, but we'll certainly try and get the patient off the mechanical ventilator mode onto a spontaneous mode of assisted ventilation, such as pressure support CPAP, very early on. By about 24 hours, we'll start weaning. And try and get them onto things. We often don't get to the point of early extubation, and we may, depending on the injuries, determine that the patient by day 5 needs an early tracheostomy. But we certainly aim to get the oral tubes out in the sort of 5 to 7 days.
Okay. Yes, and recruiting those respiratory muscles very early on.
Yes, absolutely. And it also depends on the patient. You've got massive lung contusion. That's like ARDS, and they may take 10, 12 days before they are weaned sufficiently that you can do spontaneous breathing trials. And that's the challenge. These spontaneous breathing trials and the sedation holds have prerequisites, and people are inclined to forget those prerequisites, and they just say, oh, no, you've got to wake the patient up and test them. No, he's on 70% oxygen. He's still on full ventilation. His lungs are still crappy. You can't actually do this test, the spontaneous breathing test on him, because he doesn't meet the prerequisites.
Exactly.
So as you say, that's what one has to keep in mind.
Yeah, and that's where the individualized assessment of patients and identifying their personal needs really comes into play, from a medical point of view, but also from a physiotherapy point of view. as we manage those patients in the ICU. Talking of which, what is your sort of expectation of the physiotherapists that work in your unit?
Well, I mean, I say this to them on ward rounds, is that they are the most important person in helping to get the patient out of ICU, because them doing, even if it's non-cooperative mobility of joints, even if it's just helping the patient to be properly suctioned, providing chest physiotherapy, as the patient wakes up, teaching them to take deep breaths. And again, for the patients with polytrauma, once the orthopods have put in the metal work, getting the patient up and moving. We're inclined to forget that people lying in bed, bed rest in trauma is not good for you. You lose core muscles. Especially if it's an older patient, they have all the complications of frailty. You have the risk
Yes.
of ventilator-associated pneumonias. You have the risk of deep vein thrombosis. Even with prophylaxis, the incidence, especially if you're not able to measure your levels with sort of anti-10A levels. In trauma patients, we know they need higher levels of anticoagulation, so their risk for DVT is higher, especially if they've got lower limb fractures. So there's a lot of factors that are sort of acting against the patient in terms of his recovery. So not only the physiotherapists, but also the occupational therapists, the dietitians, the psychologists, if you have access to them, they're all part of the team. And certainly as the patient starts waking up and gets off their neuroprotective phase, they become very important in the management of these patients.
Yes, no, that's definitely true. So do you do ward rounds with the multidisciplinary team in the unit?
At least once a week, yes, we have at least once a week we have a multidisciplinary ward round. But the consultants, whoever's the consultant on call, will have close interaction on the other days, particularly with the dietitian. They normally join us for part of the round every day, but they're covering 3 or 4 ICUs, so that's sometimes difficult. We generally have one designated physiotherapist for the trauma ICU at any one point of time, so we will primarily liaise with that person, and most of the time they're in the unit in the morning when we're doing our rounds anyway, and will join us or give inputs where they can. And then they will hand over or communicate with the other members of the physio team that often, once the work in the wards is done, they'll come and help the ICU people. And luckily, we also have the students from the university, and then it's great when they're there, because then you suddenly have 4 or 5 physios in your 10-bed ICU, and all of a sudden makes mobility and mobilization a whole lot easier.
Yes, definitely, and a great exposure for them, and addition to their clinical training. So that's great. By the time your patients have stabilized and they are ready to go home, are there any particular patients that you refer to an outpatient clinic, or that you follow up after discharge?
Yeah, so our burn patients, we have a burns clinic that will follow them up, usually for between 8 months and a year. And, so they've often got skin grafts and things. Once they're ready to go out of ICU, they will go to the general burn wards, and then they'll have their skin grafts and everything. And then they will get followed up at the clinic. And then from time to time, we have specific polytrauma patients where we've maybe brought out stomas, or they've had a laparotomy. They're good to go home, but they're not good to have not be followed up. So those we bring back to the trauma area, and we see them as outpatients there. We don't have a specific outpatient clinic for trauma. And obviously so a lot of our patients, because we're a quaternary central hospital, A lot of our patients, we don't have a general ward for trauma. Once they're ready to leave ICU, they step down to their base hospitals. So then the teams of physios and OTs and allied health workers and everybody else at the base hospitals take over that acute rehabilitation. Our biggest challenge in KwaZulu-Natal, and I think in state practice countrywide, is a lack of inpatient residential rehabilitation facilities. There's no
Yes.
Netcare rehab or Entabeni rehab or Alliance health centers that are spread around the state sector. So in KwaZulu-Natal, we have one hospital that's mainly set up for stomas and wounds, where they follow up the sort of central Durban, and then there's one sort of chronic care hospital. But if you're lucky, they'll have one bed available every 9 months.
Yeah.
So getting patients to what they really need. You don't want them blocking acute care beds, but some patients are just not right to go home, especially if their home is an informal settlement, and let's say they need a wheelchair. Yeah, who's gonna teach them to use the wheelchair? Who's gonna teach them to transfer? Even if they've been taught to transfer, who's gonna be there to make sure that they can get through all the little corridors and the washed
Yes.
away pathways and things like that. So you need that facility, which the private sector is very blessed with,
Mm.
and that's probably our biggest challenge. Is we spend so much money doing the acute care, and some of our patients end up going home and never really reintegrating into community because they don't have the facilities.
Yeah. No, that's very true and quite unfortunate in our country. And one can hope that maybe when the new healthcare policy comes into place, the national health insurance, that there would be some provision for this type of care in the public sector. But I guess we'll just have to wait and see.
We will have to wait and see and live in hope. Yeah, and
Yes.
that kind of brings up the whole point of 90% of trauma is preventable. And
Yes.
if you don't get injured in the first place, you've got a much better chance of remaining productive. I always on ward rounds say to the medical students with our pediatric trauma, children must be seen and not hurt.
Yes.
And so it's all those things like visibility. The guys are near a school, they must slow down. I understand why people want a 30 kilometers an hour speed limit around
Mm.
schools, because that's where the kids get knocked. Or going to a 3-year-old should not be having to go to the spaza on their own to buy chips. There should be a
Yes,
senior
exactly.
trained adult or experienced adult going with them. It's all those bigger social issues that can lead to trauma, that can be areas where we can work on prevention. The don't drink and drive is one aspect. And with marijuana being a bit more liberally legal, it's more a case of don't smoke and fly these days. But it's also things like gun control and teaching people
Mm.
emotional intelligence and
Yes,
um,
exactly.
infrastructure development. Having timely access to suitably equipped facilities. Because out in the smaller rural areas, the district hospital, if you're lucky, will have one ventilator. You have a minibus crash out in the rural areas, patients will die for lack of facilities, not for lack of enthusiasm on the part of the clinicians. So
Yes, yeah.
there's many challenges that still face this country in terms of trauma. It's not just and yes, it is a surgical disease, but it's not just a surgical disease.
Yeah, exactly. There's definitely some accountability from the community side. Tim, as we draw to a close, is there any other last thoughts that you would like to share with our physiotherapy audience?
Sure. I would like to firstly say thank you to the physiotherapists, because as I say, they're an important part, if not one of the most important parts of the team. I think long term, I actually think the dietitian is probably the person who has the longest interaction with the patients, because it takes up to 2 years for them to regain what they lose from the bed rest. But I think the physios and the OTs are probably next in line. But also our speech therapists, the social workers, the psychologists, they do, and probably most importantly, even the nurses. They spend the most time with the patients. We as doctors come in, make surgical decisions, make ICU decisions, write the orders, and we go back to our offices. And unless there's chaos reigning, we're not going to be called back to the bedside urgently for the next hour or 3. Whereas the physios and the OTs and the nurses and everybody, they're there 6, 8, not 12 hours a day, and they're an important part of the team, and they're a valued part of the team. So thank you is what I'd say.
Thanks so much. And thank you very much for your time. Professor Hardcastle, I don't think this is the last time we'll see each other for this podcast series, but thank you so much for your time today. It's much appreciated.
It's a pleasure.